P.P. Mohanan. He'll be talking about anticoagulation and atrial fibrillation, when and how.
Respected Chair and dear friends, if I take you to the pathophysiology of atrial fibrillation, which actually is very unfair at this hour, but you could see that atrial fibrillation has its tentacles into every aspect of this workhorse triad, whether it is the circulatory stasis, hypercoagulable state, or the endothelial injury. And the most important thing that happens in atrial fibrillation is stroke, and stroke prevention should be the focus of treatment in atrial fibrillation. As mentioned by previous speaker, they have a very high risk and somebody with a atrial fibrillation going into a stroke has much more mortality than a person who develops stroke without atrial fibrillation. And that's also important. If you look at the last time, the economic burden of stroke, from Sri Chitra, there was a paper which found out the expenditure of when somebody gets admitted with a stroke or ACS, and about 75% of them had to have a distress financing, which means they have to either sell their property or take a loan to manage the finances. So it's a terrible disease to have. And a huge proportion of them has a thrombus remaining somewhere in the left atrial appendage. And as I said earlier, stroke prevention is the most important management issue in atrial fibrillation. If you look at the history of anticoagulation, that is about more than 100 years old, right from the heparin, and now we have, in 2010, we have at least 3 newer oral anticoagulants in the market. Well, most of the older and the novel anticoagulants act on the extrinsic system. Basically, whenever somebody develops the anticoagulant therapy in an AF is you use a rapidly acting drug like heparin initially, and then put them on any of those vitamin K antagonists. Of course, recently we have other drugs also. Warfarin, we have enough and more data, a drug which is more than 60 years standing, which gives you a whopping 62% reduction in reduction of stroke. It is an excellent drug in stroke prevention. But then, unfortunately, its use amongst us is, us means clinicians and physicians and cardiologists, is dismal. Now, the percentage of people who are on a therapeutic dose of warfarin is 10%. So there are very many barriers to it, physician barriers, patient barriers, and possibly we can have another time for that. Many of them have, possibly physicians have the misconception that, well, if you give a DAPT, a dual antiplatelet drug, that will be as good as warfarin. But look at this. You have the reduction of stroke with the antiplatelet drug is much inferior. And this also is very interesting. If you look at the bleeding, which is one of the major barriers for the physicians to use warfarin, the bleeding by warfarin and by a dual antiplatelet, look at that. The bleeding by a dual antiplatelet drug is much more than that of a warfarin. Well, how do we decide on anticoagulating person? Does everybody with an AF needs an oral anticoagulation, which is going to be lifelong? We have some scoring system, and amongst them, the CHARTS-2 scoring is the most useful one, which gives you a scoring from 0 to 6, which takes into account the presence of other comorbidities. This has been modified the last few years by the CHARTS-2 VASC score from Europe, which has some advantage over the CHARTS-2 scoring system. They have included the lesser age group, included the women. They have also included the presence or absence of vascular disease. So if you compare the two, CHARTS-2 and CHARTS-2 VASC, now there are some advantages of using CHARTS-2 VASC score, because even it is presumed that a 0 score translated to a 1.3% will develop stroke. But it may not be so in many of those Asian countries. So CHAS2-VASc is especially useful for us. Well, the conventional oral anticoagulant drugs has been the three drugs, warfarin and coumadin, acetylcholine syndrome as commonly called, but most of the data has been with warfarin. But then, is warfarin the ideal anticoagulant? Not necessarily, because there is still the effectiveness is influenced by so many other factors. The additional the medication, food, you have to be having a regular intense INR monitoring. It is a very narrow therapeutic window. So the problems with warfarin are high, and the chances of bleeding goes on increasing when your INR goes on. And when you are on subtherapeutic dose of warfarin, then the purpose is not there. So warfarin is a drug which are useful, but then has its own problems. Of course, the problems of bleeding induced by oral anticoagulants can be also predicted by using this HAS blood score, which if you look at that, the CHAS2-VASc score has almost the same components are there in the HAS blood score also. And many a time, these scorings are not very useful, especially in high-risk patients. And mind you, these are the high-risk patients who merit oral anticoagulation maximally. Also, there is a very high discontinuation rate of warfarin. As I mentioned earlier, we need to intensely monitor the warfarin's dosage to keep it in the ideal therapeutic window. So there definitely is a need for newer anticoagulant drugs, and that is also what we got. As I said earlier, warfarin is not the ideal anticoagulant unless we were very rigorously keeping the INR value between 2 to 3. So in the search for the ideal anticoagulant, we have a few kids on the block, and these were the direct thrombin inhibitors, dabigatran, which has been there in the market for the last more than a year, and the 2 factor Xa inhibitor, rivaroxaban and apixaban, both has been approved by FDA for atrial fibrillation, and both are presently available, going to be available soon. Edoxaban is also in the anvil, is waiting the FDA approval, and so these are the 3 important trials which has used these 3 molecules, dabigatran, rivaroxaban and apixaban, in large number of patients with substantial years of follow-up. And this was the RELY trial, which my co-speaker was mentioning about. The dabigatran was used, and at the dose of 150 milligrams twice daily, it has shown its superiority over warfarin in terms of stroke reduction. ROCKET-AF compared rivaroxaban versus warfarin. Here also, now even though there was no superiority for rivaroxaban, and they could demonstrate a non-inferiority when compared to warfarin. Well, this was the 3rd molecule which is coming into the market, apixaban, and when it was compared with warfarin, there again it has shown a non-inferiority when apixaban was compared to warfarin. So we have 3 drugs which looks very promising when compared to warfarin. And if you compare, the bleeding has been one of the main Achilles heel of warfarin. If you compare warfarin versus these 3 molecules, you could see that when compared to warfarin, the bleeding episodes are lesser, especially with dabigatran and apixaban. The bleeding rates of rivaroxaban and warfarin are almost similar. So, is it all the newer drugs are absolutely useful? They have a lot of disadvantages. The first being the cost. And of course, now we don't have any data of the newer drugs on valvular atrial fibrillation, which, as I mentioned, my previous speaker, which is a sizable problem in our country. We don't have any experience of these new drugs on mechanical heart valves. And one of the important things is we don't have, unlike warfarin, We don't have an antidote for all these drugs. Of course, we have the advantages like we don't need to monitor, you don't need any monitoring, it's faster acting, and it is convenient to the patient to a great extent. These are some of the problems that I've just mentioned. I already mentioned about it. We don't have any data of the newer drugs in valvular AF. There are some possibly newer molecules which may be of use when you confront with a problem of bleeding when you use apixaban, rivaroxaban, or dabigatran. But it is not yet, most of the data are just accruing. It is too early to say that plasma concentrate can be useful as we use vitamin K for warfarin overdose. It is possible to switch if somebody is on warfarin, and if somebody wanted to change him over to the newer anticoagulants, it's eminently possible, only that you have to be cautious in your INR level. It is definitely possible to switch over, if you think so, from the conventional drug warfarin to any of these three newer anticoagulant drugs. If you look at the ESC protocol, this came in 2012. Yes, 2012. Here it is simple. If you have an atrial fibrillation due to valvular cause, don't calculate your CHAS2 score. Straight away give him anticoagulation. But if it is a non-valve AFib that you are facing, then calculate the CHAS2 score. If the CHAS2 score is 0, then they may not need any antithrombotics. If the CHAS2 score is 1, then you may choose your wisdom and give him either antiplatelets or anticoagulants. The better will be anticoagulants, because as I said, when the CHAS2 score increases, the risk of stroke tremendously doubles up. The American Heart Association, the SCCF recommendation came in 2014, and they have included, the ESC guidelines did not mention about the newer drugs. But now we have the mention about the three drugs can be used as a class 1 indications. And now here, see, most of them are class 1 indication. You could see that. Here again, there is only the 0. If your score is non-valve fibrillation score is 0, then the recommendation for the 2014 recommendation is a 2A. Which takes into account that even a 0 CHAS2 score may mean that you may have an excess risk of stroke. Well, this is the dominant. I don't want to bore you with the dosage of the newer anticoagulants drugs. This is what I was just saying earlier, recommendation which I have just mentioned right now. This is my conclusions. Atrial fibrillation, as has been said, my previous speaker is going to a tsunamic proportions. Stroke prevention is the most important issue in AF management. Use the scoring system to decide on anticoagulation. You have the whole lot of drugs available, not the antiplatelets, please, but the oral anticoagulant drugs. I will still possibly remain with warfarin because of obvious reasons. The only issue being I have to rigorously keep my patients in the therapeutic window. And who will be the potential candidate for the newer anticoagulants? Patients who have an unstable INR. Now, in most of the trials, whether it is RELY or Aristotle or the ENGAGE, which I have been also involved, the time to therapeutic range, if you keep it at about 60%, warfarin is as good as the newer drugs. So these will be the situations where I may consider the newer anticoagulants, which are not very few. As responsible physicians, we have to have a delicate balance between bleeding and thrombosis. And let us be responsible users of anticoagulation in every case of atrial fibrillation. Thank you for your attention.
Thank you, Dr. Mohanan. Please have your chair. We now have the next 5 to 7 minutes for discussion on both the papers. Over to the chairman. Thank you.
Just comments on the first speaker. When we go to the Western conferences, the data the management plan all point to the non-valvular atrial fibrillation. And sometimes we are confused that there is so many causes of the atrial fibrillation, and the management plan is quite different from the part of the world where the rheumatic mitral stenosis is more prevalent. So it is to be noted always that when we present the data of the western side, we present the data on the non-valvular atrial fibrillation because there the valvular atrial fibrillation is very less. And regarding the second speaker, may I comment that if a patient is on the, say, warfarin with the INR 2.5, you are going to switch over to the rivaroxaban, and another patient is on the INR 3 and 3.5, and we are also going to switch over. What is the dose difference of the rivaroxaban in these two patients?
I still love my warfarin. I have no intentions to switch over to either rivaroxaban or apixaban. If my patient is in between, well controlled, any time between 2 to 3.5, I have no intention to do so, but unless I have some pressing reason.
But you know that doing the INR is sometimes is not so easy in a country like ours.
Now, if you should know that the cost analysis shows the newer oral anticoagulants is 7,000 times than the warfarin. So that is a single detrimental factor which prevents me from doing that. But if somebody has a fat pocket, why not? I will give him definitely the value of the newer oral anticoagulants. Definitely.
Thank you, Dr. Mohan, for a very elegant presentation. In fact, I just had one issue to be clarified. I think the lower risk group where you have a chance 0 or let's say 1, where really, the judgment is probably more important. You really do not need an anti-platelet because one of the recommendations is used a small dose aspirin instead of the oral anticoagulant. But the reason which I was mentioning earlier, the SEARCH-AF trial, where they screened a lot of asymptomatic people and found that it's about 1.5%. And they categorically come out in this ESC 2014 that there is absolutely no role for aspirin. Would you share that thought? Because earlier guidelines said some small dose of aspirin may be protective. I am talking about low risk.
I agree that aspirin has been creating more problems than preventing the stroke. But the only thing is, we were just discussing about the Taipei paper, which was presented in the last CSI, which says that conventionally the Western data shows that if the CHAT score is 0, then my chance of getting a stroke is 1.3%. They showed in that paper, if the CHAT score is 0, their chance, the Taipei people get a stroke rate of 3.9%. So that's why, so there may be ethnic differences. So whether in Indians, if it is CHAT 0, I should give oral anticoagulation is a rather difficult question.
I think that way, I think we need more data from the Indian subcontinent on the incidence of thromboembolism, particularly stroke and AFib.
Query also, if we have a major chunk of valvular heart disease responsible for causing AF in our population, now we have emerging risk factors like hypertension, coronary artery disease, CHF patients, they are on the rise. Diabetes is considered to be another newer risk factor associated with AF. So we will now have an amalgam of all the things.
Aging also.
Aging is the most important factor.
People are aging in this subcontinent.
I told in my slide that whatever causative factor or comorbid condition you are considering, the basic phenomenon is aging.
I think one more challenging scenario, Dr. Mohan, is a patient who has a primarily coronary artery disease patient on dual antiplatelet. As an AF, we know that the antiplatelet is not really going to work. The CHAT score is on the higher side. And if you add dabigatran, you know there is a lot of data where dabigatran is supposed to produce more myocardial infarction.
I mean, the best choices in that settings will be small dose rivaroxaban. We have one of those trials which has compared rivaroxaban 2.5 to 5 milligram in those settings.
But think about the bleeding combination when they're on a triple therapy. I think you yourself showed the data where it's quite high.
True.
So what's your take on that? You know?
Well, now you may have to cut down one of the antiplatelet drugs after a period of maybe about 6 weeks if you are putting a PMS, and limit your dual antiplatelet drugs to a lesser duration. I do agree that these are all not the
too early. Yeah. Too early. If there are any questions from the floor, we would welcome that.
Okay, if there aren't any questions, Mr. Chairman, we move on with the presentation ceremony. May I firstly invite Professor Majumdar to kindly step forward and present a memento to Dr. Gulati. I would like to invite Colonel Kapoor Please step forward and present a memento to Dr. Mohanan. Thank you very much, gentlemen, for chairing the proceedings of this session.